My name is Liddy Dulo. I'm a nurse by profession with other specialties. I work for KMET in a program known as Maternal Health Innovations under Reproductive Health. So today, on behalf of KMET, we want to share with you some of the innovations that we are having. And some of these innovations, you already know them. We've interacted, just as mentioned. And so today we specifically want to talk about postpartum hemorrhage. We know that women are still dying despite the many, many interventions that we have. And so we have singled out on postpartum hemorrhage that is still a #1 killer to our women. And in this forum, we want to find out how can we progress and improve the quality of care. We will talk about the journey that we have taken with these innovations. We're also going to talk about the implementation process, the achievements we have gained through the process, and we want to have a way forward in managing postpartum hemorrhage. So in my preamble, I just want to mention a few key items or issues that KMET doesn't work alone. And so as KMET, we work with the Ministry of Health and other partners. One of them is Harvard University and Massachusetts General Hospital. So in 2012, we came together as a team to introduce the uterine balloon tamponade to manage uncontrolled PPH. This has been supported in many areas. And if we can remember the first confidential inquiry of maternal death that was done in our country in 2017, it gave a confirmation that PPH is still the #1 killer of our women within our facilities. And again, it has been confirmed that there are many delays despite the interventions that we have when we prevent and treat postpartum hemorrhage. And some of these delays are due to lack of blood and blood products. Staffing issues are also there with us. And that has led to continuous unacceptable rates of maternal mortality. And these are all preventable maternal mortalities that we can manage. We have another confirmation by WHO. This was a technical consultative team that sat down to look at what else can be done apart from the interventions that we have. And so they came up with the bundle approach and recommended it to be used in controlling postpartum hemorrhage. So as KMET, we picked it up, and from uterine balloon tamponade for managing PPH to the bundle approach. So why this bundle? And what is a bundle? In our class 1, 2, and 3, or from nursery, we talk about a bundle of sticks. So we're also bringing a bundle in health care. And so we are saying care bundles it's an organizer. It simplifies patient care. It reinforces teamwork. And again, a bundle care is a stepwise approach using the acronym of MOTIVE. So when we talk about a bundle of care, we're looking at doing a massage, using oxytocin drugs, using tranexamic acid, and IV fluids. That is already a bundle of interventions together to manage PPH. So in this bundle, we have clinical and non-clinical components. Most of us know the clinical component, and that's what we stick to. But WHO is bringing up the non-clinical component, which we will briefly see or talk about. What are these non-clinical components? And so for us to have the bundle succeed, we must put systems in place. Our facilities must be ready so that we manage postpartum hemorrhage. So I had already mentioned that WHO came up with this intervention so that we bring down our maternal mortalities, targeting our SDG in 2030. So bundle care, I'll briefly explain what it means and what we mean by a bundle. So when we're talking of a bundle, we are talking about interventions that will help us achieve hemostasis. So when we are talking about a bundle approach, we are saying that we want to respond very fast so that we manage the situation. And we are saying the first response is uterine massage. We want to put up IV fluids. We want to use our oxytocic drugs. We want to use tranexamic acid. Then we have other interventions. We call them supportive measures. We have to ensure that all tears are taken care of. We have to ensure that the bladder is empty. And if we have a retained placenta, then we must do a manual removal. Then we have refractory PPH interventions. We have the compressions. We have the uterine balloon tamponade and the anti-shock garment. Then we have supportive interventions where we have blood transfusion. If we're in a facility that can't manage PPH, then we are going to refer this patient, and the patient can still go to theater. So this is a comprehensive management of PPH called a bundle approach. So this is the clinical way of managing PPH. The non-clinical way, the model that is encouraged by WHO, is right here. So on this circle, we are talking about the patient who is in the middle. And we are saying our facility must be ready. If our facilities are not ready, then we will have maternal mortalities. How do we get our facilities ready? We must have enough staff. We must have enough equipment for managing PPH. Then we also must work as a team. Teamwork and communication has failed us as health providers. We concentrate on giving medication, but teamwork and communication has failed. And so to manage PPH, we must work as a team. It's a multi-sectoral approach that we are using. We must have our network integrations. Some of our facilities don't have ambulances. Where else can you get an ambulance? We must network with the nearest facilities around us. We are also saying that respectful maternity care must continue. We can't emphasize this more than we have ever done it. We are also looking at data monitoring and quality improvement. Our quality standards in our maternities have gone down. And so from this meeting, I hope we will be keen on improving quality standards to manage our patients. Then we are talking about leadership, which is rarely talked about in medicine. Why is leadership the last circle? Without leaders, we may not do much. Our leaders are the policy makers. Our leaders are the ones who guide on procurement. So for us to have a ready facility, then we must include our leaders. So with the clinical approach and the non-clinical approach, we are going to bring down our maternal mortalities. So as KMET, in partnership with VAYU, we came up with an organizer, an emergency kit. If you throw your mind back in your facility, there's a small box somewhere with IV fluids, and we call it an emergency kit. When PPH occurs, this kit must be poured down for you to pick what you really want. So these are the delays we are talking about in the facility. We have come up with a PPH emergency kit that is organized as per the protocol of management of PPH. We have the first response line. We have the supportive measures. We have the uterine balloon tamponade here and the anti-shock garment. So this is a kit that can be folded. It can be in our ambulances. It is portable. Even if a mother was delivering at the gate, you can easily pick it and go with it. It can also help us during handing over as nurses in maternity. if I used the 2 fluids and you're coming on duty, you will realize that the 2 IV fluids are not there, and it will be easy for you to replace. So that is why we call it an organizer, and we can talk much about it down at the booth. So how have we implemented this program? We don't work alone. We believe in working together with our partners and the Ministry of Health. So we do county entries and inception meetings where we can meet the governor, the CEC and his team, and explain the interventions that we have in management of PPH. And then we come into an agreement and sign a memorandum of understanding so that we work together as a team. And we like having the county leading, and we support them. Then we also meet the CHMT and take them through the training on how to manage postpartum hemorrhage using the bundle approach. Mapping of facilities is done in partnership with the county that we are going to train. Facility selection, provider selection, we don't do it because the county team knows their people best. Then after this process, then we plan for a training. We first train trainers who will go and cascade the training into the facility. So we call it facility-based trainings. And that has been very effective because it includes everybody. We are running away from hotel-based trainings where we have 1 or 2 persons. Then we have commodity supplies. Without commodity, we cannot manage postpartum hemorrhage. We have continuous mentorship and support supervision. We also document these stories because these are new interventions that are there. And we also do advocacy. Our advocacy is focused on budget allocation for training and provision of commodities. And as we advocate, we are looking at sustainability of the commodities. Now, I want to talk briefly about a county where we piloted this, the bundle approach, and we had very good results. So in Migori County, this is one of the 15 counties that have high maternal mortality. So our pilot was in Migori County. We selected with the county 12 facilities, they have and spokes, and we trained trainers who also went and trained the other champions and continued with the mentorship within the facilities. So this started in 2019, and in 2019, their maternal mortality was still high, was 11. PPH recorded cases were around 330. And at that time, their fertility rate was 3%. Then 2020, they went to 4%, 2021, 2%, and 2022, 1%. In 2020, the bundle approach was not yet embraced as much as they had embraced it by 2021. And we started with the 12 facilities, but by the time we were reaching 2022, the mentors had already cascaded, rolled out the training to all other facilities. And around 168 facilities in Migori were already implementing the bundle approach. And that's what brought the fertility rate to 1%. So this was a great achievement that encouraged us to continue training and training and training. And so what is our way forward? We want to support training of trainers to accelerate rollout. And we are happy that the Ministry of Health has embraced this, and it's already in our mentorship manuals. For those who have gone through the training, it's already in our mentorship manual, and this will help us roll out very quickly because the mentors will go into the facility and mentor each and every staff. We are also saying that, we are also saying that we need to integration of bundle care into MNH interventions. So if we were training on PAC and we are training on PPH, there are some of these interventions that can be merged together. So we can look at how to integrate into the ongoing services, even in our CMEs. And finally, we are saying that we advocate. We must have supplies for us to be ready to manage PPH. So these supplies can only be within our budgets, and so the advocacy now is about budget allocation for the resources, and this will give us sustainability. These are some of our partners that we work with. We don't work alone. Managing PPH, I've said it's a multi-sectoral, so all these partners are with us in it. Otherwise, thank you.